This week, I sit down with Kylie Baker at the GE booth at SMACC in Sydney. Now, this is a very fun interview that I had with Kylie in which we discuss our favorite non-ultrasound ways to manage patients in conjunction with our ultrasound. Ultrasound should not be the sole way that we help manage our patients. We have to use that along with other things, including the things that we like using the best. This podcast was sponsored by GE. If you want to learn more about the point-of-care ultrasound products that GE has to offer, check out their website.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Hello, this is Jacob Avila of Ultrasound Podcast. I'm joined by Kylie Baker, someone who I've interacted with a bunch on Twitter. Super excited to actually sit down and talk to you. Kylie is an emergency physician in Ipswich, the Ipswich Emergency Department,
Yes.
Which is a little bit north of where we are right now, right?
This is true, yes.
Okay, yeah, and where we are right now is we're actually in Sydney, Australia at the last SMACC. I'm pretty sad about it, but it is the last SMACC. And we are here at the GE booth, and Kylie and I wanted to talk about something that it's interesting because I think we're both passionate about, but we have slightly different viewpoints on which it's good, right? I mean, it's great. It's important to talk about it and see how we practice slightly differently, right? So the one thing that we wanted to talk about was the idea that ultrasound is not the only thing that matters. And that's kind of a controversial statement coming from the Ultrasound Podcast, I think, right? But it's true. It's not the only thing that is going to be in the room that you can use to help save your patients' lives. An important thing. So one of my big things that I talk about is that ultrasound is not the only thing. It's a tool in your toolbox. It's an arrow in the quiver. And don't tell anybody, but there are some shifts in which I won't touch an ultrasound machine because it's not necessarily going to speed up disposition on my patients. I mean, I'm seeing 10-hour shift. I'm seeing occasionally like 50 to 60 patients an hour. I just don't have time to do it, and I don't touch it. Usually I'll have to place an IV or two, but I'm not echoing all of my patients. What's your experience?
Well, I think the only shift I don't use an ultrasound on is telehealth.
Wow.
I sat and I thought,
Really?
and I've touched an ultrasound pretty much every single shift for maybe the last 10 years, except for telehealth.
Wow. So what is like your most common application? Like, are you doing like a broad thing, or is it like every time you're doing an echo for sure, like every shift at least one echo?
No, I actually audited it 1 year, about 18 months or so, and the most common thing I'm asked for is right upper quadrant,
Really?
believe it or not.
Okay.
Yeah, I think people just want another opinion, they want another set of hands to look at their patient, and right upper quadrant's one of the most nebulous of the examinations. So for us, that's what I do. Then it's peripheral cannula, lungs, and heart.
Gotcha. So how many peripheral cannulas are you placing on a shift?
2 or 3.
Yeah, that's a good
perhaps.
amount. Do you have nurses that are trained to do it as well, or other physicians?
Not so many with ultrasound, so I get the hardest ones.
I see.
I think I'll be in use even when I'm 80, just doing peripheral cannulas.
Yeah, fair enough. I'd say it's a huge skill to have. I actually struggle with this because I feel like my residents aren't really learning how to place central lines because they're doing so many IVs, right? All right, so I love how much you're using ultrasound. It's inspiring. Maybe I should do it more. Now, besides the ultrasound, give me your top 3 non-ultrasound things that you use to help your patients on an average shift.
Right, this is where we differ, and I think this is because I think medicine in Australia is a lot less technical.
Okay.
My answers were a good history.
Okay.
And my eyes. I mean, for me, an ultrasound replaces ears and hands. I don't use my stethoscope. I was never very good at it anyway. And to me, ultrasound's also a palpation tool. You don't just look at the screen on the picture, you bounce and you play and you interact. But none of that's any good if you haven't taken a good history or at least look for a background. So I put those things up ahead of ultrasound, but then ultrasound comes in immediately. It is my examination. I tell my residents that I can't think now without an ultrasound probe in my hand.
Yeah. It's interesting because I feel like, in a sense, we are saying the same thing because I'm saying you can't use your ultrasound in isolation. I like to focus in on toys because I like toys.
I
I have a lot of toys I like. Let's take just a beeline, right? Let's say like we see an ultrasound and we see beelines. that could mean anything. Like, they could have any pulmonary pathology, right? And we have to have the history, we have to have the physical exam, maybe even an EKG, maybe some labs, to kind of help us, push us towards this beeline means this particular thing.
Of course. Yeah, Justin Barrow says you still got to be a doctor.
Right.
Got to be a doctor.
Exactly. Exactly. All right. So you got your H&P. What I like, one of my favorite things is actually an art line and an art line waveform. To me, that comes most in useful when you're coding patients, because I don't know if you've been in this situation, but you're coding and people are doing chest compressions, you're doing the pulse check, someone else is doing the pulse check, and they say they can't feel a pulse, but you see enough squeeze, like there's enough squeeze in that heart that they should have a pulse, but people can't feel it. The reason I like the art line so much is because you can have a quantitative number that you can say their diastolic blood flow, their diastolic blood pressure is 45, which is enough to perfuse the coronaries, right? And you can not worry about the pulse check as much. That's my number one favorite non-ultrasound thing to have.
Yeah, maybe.
So what do you do?
I don't think we've usually got the outline in by that stage, I've got to say.
Yeah.
The other thing that worries me is that your outline's a peripheral pressure and a peripheral diastolic, whereas the central perfusion might be a little bit higher. There was something on Twitter just recently about the difference in the central waveform and the peripheral. So, but it doesn't matter. Just because I'm not good at it doesn't mean it's not a good thing.
Fair enough.
It's just probably came out after I graduated. That's all.
Yeah, well, and usually I actually think that in general a radial art line is much harder to place than a femoral art line, and especially in coding situations because their arms just flailing around, right, when you're doing compressions.
So you're talking about femoral art lines.
Femoral art lines, yeah. I usually am placing the femoral art line, but still it's difficult, right? Yeah. But that's like my number one favorite one. Now, what about, is there like a medication that you don't think you could live without?
Lignocaine, xylocaine, perhaps.
Okay, yeah. So you're talking about for like if people have cuts that they need fixed?
Oh, for anything. No, I shouldn't say that. I'd probably say magnesium. That'd be my favourite one. But no, to me, ultrasound isn't in the same box as medication. But at the same time, I do use the time that I do ultrasound as a therapeutic intervention. This is when you sit down with the patient and you demonstrate to the patient that you have time for them. Right. And you chat. Yeah. You make yourself comfortable, you gel them up and you ask them have they ever had an ultrasound before and does this hurt? And you can actually take a history and at the same time you can talk to them about their pain or their exercise tolerance or whatever it is you're looking at. And you can start to introduce ideas or reframe their experiences. So although I slag it off and say ultrasound is not a drug, that's wrong. I think you can use it
I hadn't thought about that. Wow.
To establish a relationship and even start to influence how they're thinking about the illness.
Yeah, no, that's that my mind.
But
is
I do like
right
magnesium.
All right. Wow, that's, like I said, mind blown. So kind of along those lines, how do you physically use the ultrasound machine on shift? Are you just bringing your ultrasound machine with you to every patient? Are you on a Segway, pushing the ultrasound machine in front of you to every patient room? How are you actually doing this?
Well, all my residents will say it's part of me. And yes, on the odd occasion, I leave it outside the room to remind myself that I must talk to the patient first, particularly if it's a child or an older person who might be afraid of a big machine. So, but yes, it goes with me to pretty much every patient except the psych patients, because I'm a bit worried that they'll hurt it.
Yeah.
And I start to talk to them, but as soon as I sort of have their permission to start an ultrasound, I basically talk and scan at the same time. I'm in favour of multi-system, almost total body scanning, but because I can talk at the same time, I just sort of drift from one end to the other usually. It is important, I think, though, to take a history first, because you can go down a rabbit hole once you find something interesting, and you can be distracted. So, although it goes against the grain, if I'm seeing a patient primarily myself, I'll leave it outside the room. But if the resident's done the work first and has just asked for my opinion on an appendix or right upper quadrant, then I can go in straight away.
Gotcha. So you have residents, now they're called residents in Australia, so because they're registrars in Britain,
they're
right?
both.
They're both.
Yeah,
oh, okay. Learning stuff here. All right. So do you have enough to like, you're always seeing patients with residents, or are you seeing some on your own?
I'm seeing some on our own,
Gotcha.
mostly with residents, but usually by the end of the shift there's someone you're worried about and you're sneaking yourself.
Gotcha. Okay. All right. So what is your, I guess, your all-time favorite non-ultrasound procedure to do?
All time. I know this sounds really weird. Talking down psych patients.
Really?
Yeah.
So verbal de-escalation is your
Verbal
favorite
de- well-
procedure?
Well, it's the only thing I can do without an ultrasound machine. Everything else I can use an ultrasound machine for.
Wow, that's interesting.
Yeah.
Do you
I
have any,
suppose
like,
I
give any
haven't delivered
tips?
a baby without well, even that. Do I have any tips?
Yeah. Like, what is your go-to when you have like an agitated psych patient? For us, we have a lot of, unfortunately, we have a lot of schizophrenics. We also have a lot of people on drugs. So, like, give me a tip. Like, how do you do it? I'm fascinated here.
I just put on the grandmother look, and
Got it.
shrink down and look sweet.
Really?
Always
So you
address them by
disarm them with sweetness.
Yes.
Yeah,
Yes.
that's
And
brilliant.
vulnerability. I mean,
Yeah.
they don't know that I can run.
Right. Wow, that's awesome.
Yeah.
All right. So, what do you think the role of non-ultrasound imaging is on your average emergency department patient? Do you get X-rays?
Yes, and I think this is where you really start to meld your ultrasound from your exam with your investigations. For me, lovely case recently where we had a patient who was very short of breath.
Okay.
And I was scanning, I saw a lot of fluid in left hemithorax, but I also saw a dilated aortic root. Now I'm a bit slow, I am, because we don't have much trauma, etc. at our place. But just because there's a big aortic root, I then went to the chest x-ray and had a look at the mediastinum and thought, ooh, that is unusual. And from the chest x-ray, we then went to the CT, which was a ruptured thoracic aneurysm.
Oh my
now,
goodness.
the thing is, you use the ultrasound to help you look at the CT or to show you where to look at the chest x-ray, because when you're using the probe to palpate the abdomen, you know which bit is sore, so you then go and look in the CT specifically at the left upper quadrant or the left lower quadrant. So for me, ultrasound helps me see the other tests.
Gotcha.
That's
brilliant.
Yeah, and it's not the only thing. There are times. I mean, you have ultrasound. Let's say it's got a sensitivity of 90%. X-ray has a sensitivity of 40%, 50%. There is going to be a time when ultrasound is going to miss that one thing that X-ray might actually catch.
Well, you've got to know what you're looking for. If you're looking for something that has a surface distribution, obviously you want ultrasound.
Yeah,
but if you're looking at something that's hilar in the lung, you've got to have a chest x-ray. So you just know, am I looking for a procedure, a process that starts perihilar, or am I seeking out a process that starts peripherally? Then you know which one to pick up first.
It's all data points. I obviously love ultrasound. You obviously love ultrasound, but it's data points. The most important thing is to understand, I think, that our goal is to not necessarily do cool things with ultrasound. Our goal is to help our patients, and it happens that ultrasound is usually the best thing to figure out how to treat your patient, but it's not necessarily.
You got to practice. Like any other tool, you got to practice.
That's true. A bit of a learning curve with that. Wow, amazing stuff. Really appreciate you sitting down with me. Really appreciate the tip of the taking down the verbal de-escalation for psych patients. That's huge. And hopefully we'll be able to do more stuff in the future.
I'd love to. It's really great to meet you. Lovely that you come down here.
Right on. Thanks.
See you.